Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome back. This is part 2 of the communication skills in pediatrics with a special emphasis on breaking bad news. I'm Professor Muhammad عطية البيومي, Professor of Pediatrics, Faculty of Medicine, Mansoura University. In part 1 of this lecture, we've discussed the principles of communication, the communication model, what are the situations in which we communicate in the medical environment, and we've explained the technique of spikes: setting, perception, invitation, knowledge, emotions, and summary. We've discussed that we always need to remember that hand washing and face masks are among the most effective ways of preventing transmission of COVID-19 infection. I want to take you now into the process, how we're actually delivering the information. I'd like to classify our interview with the parents into 3 parts: the introduction, the content, and the conclusion. It's the same way like spikes, if you like, but that's a different way of doing things. You might find it easier to remember 3 parts rather than remembering the 6 parts of the spikes. At the end, we'll be doing the same thing. At the end, you will find out that it's exactly the same thing. For the introduction, you introduce yourself. You make sure you're talking to the right person. You establish the rapport. I'll come back to that. You clarify what the objectives of the meeting are, and then you agree the agenda. When you introduce yourself, you start with "Good morning, my name is Dr. X." If you call yourself doctor, then what follows this title is your family name. I cannot call myself Dr. Muhammad. I'm Dr. El-Bayoumi. I can say, without the title doctor, I can say in a more informal way, I'm Muhammad. I'm one of the doctors working on the children's hospital. But if I call myself doctor, please remember that what follows the title is the family name. A part of introducing yourself is to introduce your job. Who are you? What is your job? Then you make sure you're talking to the right person, that you're not confusing one parent for another. You are talking to the mother of Hussam, for example. Then you establish a rapport. A rapport is actually talking with the parents about something unrelated to the task, unrelated to the situation you're going to talk about. Then you clarify the agenda of the meeting. Why do you want to talk to Hussam's mother today? And you make sure that they agree that this is a good time to do so. So that's the I of the spikes. You agree, you both agree that this is a good time to talk about whatever you want to talk about. Then you're delivering the content. So it's an introduction. Then you're delivering the content. You use the appropriate language. You deliver small chunks of information, checking understanding after each and every part. You stay correct. You stay true. You don't give false information. And don't go into monologues. Don't go into very long lectures. Don't try to show how much you know about the subject. Remember, is not the skill of checking how much you know about the subject. Don't go into a lecture. Always keep an eye contact with the person you are talking to. And actually, the psychologists will tell us that when you're looking into someone's face, you look into a triangle which is between the eyebrows and the chin. So this is the face you're looking into. Don't look at someone below the chin or above the eyebrows. And it's always better to keep an eye-to-eye contact. When you show interest, how do I show interest? I can do this with my body language. I'm leaning forward. I'm keeping an eye contact. I keep head nodding. So this means I show interest. Then you listen for feeling. If someone's facial expressions go sad, or you notice that there is a shock on the face, then you need to address that. You say, oh, is it okay? Should I carry on? I can see you're not feeling very comfortable with what I'm saying. This will show the parent that you're actually engaging in the two-way communication. You're not there just to throw the amount of info that you have and leave. Then you go through what we call the signal encouragement. Signal encouragement means that you keep asking them if they are talking, then you say, right, okay. Did that really happen? Something like that. And then you go through encouraging them to talk. And of course, while you're encouraging them to talk, you're avoiding to interrupt them. You avoid interruption. And then you reflect. I'm not going through everything. I'm just going from the top right corner, stopping at very important parts of what you need to do to show that you're practicing active listening. Then you reflect. What does it mean, reflect? Reflect means you interpret what the parents are saying. You say, right, okay, so you really want to tell me this and that. So it's paraphrasing. You're repeating what they have said in your own words. So that means you're reflecting. Reflection that means you're understanding. Reflection means that you give meaning to what they say. So you want to tell me that Hussam wasn't doing very well at school in the last few weeks. So you're giving a meaning for what they are telling. The next point is actually to avoid prejudice. Prejudice is pre-made decisions based on gender, based on race, based on religion, on skin color, based on dress code. So for example, the common mistakes that we go through prejudice, if there is a big, bulky, muscular man from a rural area, he must be a tough guy. He would not be crying if I tell him that his son has got a cancer. That's a prejudice. That's a pre-made decision that you're going to talk to this man making assumptions. No, you should not be making assumptions or a pre-made decision. A woman with niqab, I should talk to her about religious beliefs. No, you don't go there. You do the same with everyone with no prejudice, no pre-made decision. You use open and closed questioning. I'll come back to this in details on the next slide. And then you clarify. So if something is ambiguous, something you don't understand, you ask them to clarify. Can you clarify more? Can you tell me more about that? I don't get you there. Can you please say more about this? And then you summarize. And you show interest. It's not really a cycle. It's not like you're doing it in this order as it is a circle or something. No, these are the components of the active listening. You do all those components together. It's a skill that you need to acquire. And I can tell you that this is a life skill. This is not a skill only for communication within the medical environment. This is a skill to communicate with anyone in any scenario in life. We just mentioned that you use closed and open questions. What does that mean? A closed question is a question with a yes/no answer. An open question is an inviting question. So let us have an example. This is an open question. Tell me about the bowel habits of Hussam. Tell me about the bowel habits. They will keep talking. But if I ask the question saying, has Hussam got constipation? Then the answer is yes or no. That's not really an inviting question. So I'm not going to get the information I need to know. So as you remember, we've said that we divide our communication with the parent into three components: the introduction, then the content, and then the closure. The closure will be the similar to the S of the spikes. If you remember in the previous lecture, you summarize, you highlight the very important info that you've given them, you agree the plan, give an opportunity for a second meeting with the team, refer to a support group, give leaflets, booklets, info, websites, support groups, ask if they have any questions and answer them. And of course, don't remember to greet them, and then you leave the room and end the meeting. Remember, when you're sneezing, is to sneeze in your elbow in the same way. Don't sneeze in each other's face. Maybe you can use tissue, but that's again, if you don't have a tissue in hand, you can sneeze in your elbow. Now let us go for an example of breaking bad news, and we'll have a scenario and we'll see what the possible situations can go like. Of course, we need to practice this in a live face-to-face session. We'll try to organize that, but let us have the principles in this video. An example is you're a junior resident, maybe you're a house officer, and you're talking to the mother of a 4-year-old child called Hussam, who is admitted last night with persistent vomiting, and the investigations are out and show that Hussam has got diabetes, and the task is to explain to the mom. Of course, we'll go through the spikes, we'll go through the settings. So we'll go into a quiet, private room. Make sure that the time is uninterrupted. You tell your nurse that you're having a parents' meeting and you don't want to be interrupted. You switch off your mobile phone or hand it to someone to answer if something important comes through, but that's how it goes. The other technique which we just discussed is the introduction, content, conclusion. I repeat again, they are exactly the same thing. So what happens with the introduction? You introduce yourself, you make sure you're talking to the right person. We've just mentioned those steps. How should we actually word those sentences? I start with something like, good morning. I'm Dr. Al-Bayoumi. I'm one of the doctors looking after Hussam. I understand you're Hussam's mother, is that right? Then in that sentence, I've done two things. I introduced myself and I made sure I'm talking to the right person. Then I go through the agenda and the invitation. Before doing that, we go to the rapport. So I know you spent your last night on the ward. Did you manage to have some sleep? It gets a little bit busy sometimes and noisy on the ward. I'm apologizing for that. Something to talk about outside the issue of diabetes. If they came to the clinic this morning, maybe you can ask about the weather, you can ask about how the travel to the hospital was, something like that. They call it rapport. You might find it in some references called ice breaking. It's exactly the same thing. Then you clarify the objective of the meeting, saying, I'm actually here to talk to you about Hossam's case. Is it a good time to do so? Is it a good time to do so? Is the invitation we've talked about in the spikes technique. Then you ask if the mother wants someone else to be around. Do you want others to be around? Would you like someone else to be with us? So that's the introduction. Then you say, I'll tell you what we've got. Please feel free to ask any questions at any time. So you're telling the mother, this is a dialogue. I'm not going to talk all the way on my own. Just ask me anything that you'd like to ask at any time. So we've done the introduction now. So we've fulfilled all the items on this slide under the topic introduction. Then we go into the content, and we're delivering bad news. Those in the light color in the screen can actually be other scenarios that you need to perform. Maybe you'd like to deliver information about changing the medicine on an asthmatic child. Maybe you need to obtain a consent for splenectomy in a child, something like that. So, but we're agreeing from the very beginning that we're putting emphasis on breaking bad news. So for the content of breaking bad news, you establish a common knowledge base before you start talking about the new information. You need to explore what they know already about the child's condition. While you're delivering information, you use no jargon. Jargon is words that make no sense to the parents, maybe very sophisticated medical terminology. I'll actually be showing you one of my favorite examples for using jargon. It's a part of an Arabic movie called Karkar. So let us have this, and it was meant to be funny, but it's actually very educational because it has so many mistakes of what you need not to do while you're breaking bad news to the parents of patients. Let's have a right. What happened there actually was using a huge amount of jargon. And whenever he's tried to explain, he would use actually more and more jargon. That's why it ended up in a confrontation. There was a huge amount of disagreement. It turned into a conflict, not breaking bad news. So there was a lot to learn from this clip actually. Use no jargon. We've watched the movie. Then you start saying, establishing the prior knowledge as we've just mentioned. Tell me what you know about Hossam's condition. The mother will say, oh, we've come in last night. He had really bad vomiting and it wouldn't stop and he vomited everything and this and that. Then you give the warning shot that we've agreed. I'm afraid the results we've got are not as good as we hoped. So that's again, preparing the mother to receive the information. Then there has to be a pause there until you get a clue that it's a good time to carry on. You will get a clue if the mother asks, oh my God, what is it, doctor? So she's ready. Or you can observe again in a visual, you have a visual indicator that she's interested in knowing. Then you actually deliver the new information, calling the disease with its clear name that the parents will understand. I not go into this is lymphohistiocytosis. That's for them that's a jargon. But diabetes is not a jargon. You say something like, sorry to tell you that Hussam has got diabetes. Then you pause again until this piece of information sinks in before you carry on delivering the next part of the information. At that stage, there must be some sort of emotions coming out. But if there are no feelings, go and find them. Go and do some probing. Why is she not feeling upset with this piece of information? So maybe you go and start asking a question. Did you expect this to be a cause of Hussam's vomiting? So you're actually here, you're exploring feelings. If feelings don't come out, you have no chance of delivering the further information. Then after the emotions, after the pause, you start carrying on. What does that mean? What do we need to do? These are the questions that the mother might ask. And if that doesn't happen, maybe when you get the indication that it's a good time to carry on, that you say something like, can I talk you through now what this means to Hussam in the next few days? And then you start talking about the implication of the new information, for how long Hussam is going to stay in hospital, what sort of treatment is Hussam going to receive, who is going to look after Hussam, what sort of follow-up does he need, how his food is going to be like. You started delivering all the information related to diabetes. I want you here to remember that there is only as much that the parents can take in a single interview. So I want you to focus on the short-term implications of the diagnosis. How long is he going to stay in hospital? When does he go home? What sort of treatment? How is he going to be followed up at home? So it's probably too early to go through diabetic retinopathies and the vasculopathies. And if you don't do this, if you don't do that, he's going to lose vision. It's way too early. Okay, we're not talking about very long-term implications of the condition, because that's not going to be the last meeting. We're going to meet again in follow-up visits, and we'll be discussing the long-term implications. So my message here is not to flood the parents with a large information so they will not keep any of what you told them. So what do you say next is showing empathy. I'm sure it must be really difficult to know that your son has got diabetes, something like that. Then you start going on the impact of the information and start to give silver lining. Silver lining means the light at the end of the tunnel, means to give some hope. To give some good news among the bad news. However, the good news is that he's stable, and thanks to your care, the diagnosis was made quite early. It's a very good thing of you that you brought him in that early. We're confronted with so many parents who bring in their children with diabetes very late. I'm giving a true piece of information, but again, that's an encouragement, that's a good news. Then you go back to the focus and go back to what happens next. So this is the spirit of the interview. Then you have to respond to questions. Of course, there will be so many questions coming out at that stage. We'll be showing some questions, and we'll be showing some possible answers, and I want you to think about every answer that I'm going to show, whether it is a good answer, appropriate or not. The first question, of course, will be the denial. Are you sure of the diagnosis? Could the results be confused with another child's results? Could the lab be wrong? All those questions you can be asked. Possible answers are, actually, we can repeat the test to be sure. We are 100% sure. We're never wrong. Are you accusing us of being non-professional and malpracticing? Why would I tell you if I wasn't sure? What do you think about those answers? We'll be showing red and green and yellow for each answer. Red if it is inappropriate, green if it is appropriate, and yellow if it is in between. If you need to repeat the test, go and repeat the test before you tell the parents the results. So you don't say that. We're 100% sure is a very good thing to say, because this puts the denial away from the equation. This child has got diabetes. There is no way to deny this. We need to focus on what happens next. We are never wrong. I'm not sure what you think about we are never wrong, but I'll give it a red card. It's inappropriate. It's not about us. It's about the test being true. It's not about us being right. I'm not defending myself. It's a very defensive statement. We are never wrong. Of course, are you accusing us of something is a big red, and it's a very confrontational and aggressive statement. You're actually inviting a conflict with this poor mother. Why would I tell you if I was not sure? Again, that's a very aggressive statement. You're attacking the mother. Just simple answer. It's a part of the grief cycle to go into denial and blame. I'm not going through this in details on this occasion, but maybe on other lectures. When you receive a bad news, and if you remember, when you in life received a bad news before that, the first thing comes to your mind that it must be wrong. It's a denial. It's a bad news. It's a false news. I mean, it's not true. So the mother has to go through denial, but you need to get the denial out of the way, saying that the results we've got is actually true. The second part that parents or anyone who receives a bad news will go through is the blame. They will try to blame someone. Sometimes they blame their child for being naughty. They blame themselves. They might blame you for not looking after the child properly. So even if they blame you, you know that this is included in their normal, what we call the grief response. Don't take it personally. They have to blame someone. And that's the example. In this case, this mother is trying to blame herself. Was it my fault? And the answers are not necessarily yours. It's a disease that children get from their parents. It's God's will. It's not anyone's fault. It was just a bad luck. What do you think about those answers? Not necessarily yours means it is someone's fault. It may be yours, it may not be yours, which is again, it's a wrong answer. It's a disease children get from their parents. There might be some hereditary roots for diabetes, but again, that's not, even if that's the case, it was not the parents' fault. So that's not the answer. Was it my fault? You say, yes, he got it from you, but was it my fault that he got it from me? No. So despite being not completely wrong as a piece of medical information, but that's not the answer to the question. It's God's will. This is a bit tricky. Everything in the universe is God's will. But again, in that context, we try not to mention the interference of the superpowers. We try to talk about our world facts that we know. So it's God's will is a controversial answer. I put it on purpose because we say it all the time, but actually in the science of communication, it's red. You don't talk about that. I know someone will say, but we have our own strong religious beliefs which might help. Use the strong beliefs if you think they will help, but be aware that you should not do that as per the science of communication. It's not anyone's fault. I like that answer actually. It's not anyone's fault. No one has done anything wrong, which resulted in Hussam getting diabetes. It's just a bad luck. It doesn't help me to tell me that my child has got diabetes because of bad luck. Again, that's a superpower that I have nothing to do with. So don't say it's just a bad luck. It's not anyone's fault. In this context is a very appropriate response to the question of the mother, was it my fault? No, it was not anyone's fault. So we're trying to give hope. But while we're giving hope, we have to stay true. And remember the sentence that we've said in the part 1 of this lecture, that is not kind to lie, is not kind to give false hope, that's not a kind act. So is he going to be okay? That's the question that will come out in every conversation. So possible answers are, yes, I promise. Sure. You will actually go home today. I know children who are doing very well with diabetes. We'll have to wait and see. What do you think about those answers? Yes, I promise is red, because you cannot be sure that he's going to be okay. It's an unconditional answer. Yes, he's going to be okay. No matter what happens, yes, I promise he's going to be okay. The same is for sure. It's a very short answer. Doesn't give responsibility for the parents to do, doesn't put any conditions on how this child's condition will go. You will actually go home today. They don't go home on the next day. Children with persistent vomiting, recently diagnosed diabetes, don't go home on the same day. I know children who are doing very well with diabetes. I don't know what you think about it, but I'll give it yellow. It's not wrong, but it is not complete. It's nice, but it is not complete. Yes, you know some children who are doing very well with diabetes, but who are those children? How are they treated? How are they followed up? So it's a nice statement, but it is incomplete. We'll have to wait and see. Wait for what and see what? We're still giving the initial treatment. We sometimes use "we'll have to wait and see" when there is nothing that we need to do. And when I say nothing we can do, there is nothing that we means the doctor and the family. But for Hussam's condition, the doctors are still having to treat him, and the parents will have their participation in the management plan when this child goes home. So that's not the scenario when we say we'll have to wait and see. Wait and see when we've done the treatment and we're waiting for the response. So there was no green on the previous slide. This one is green. Actually, most of children with diabetes who are compliant with treatment and strict on their follow-up will achieve control and lead a normal life. So it's giving hope based on a true information and putting responsibility on the parents that it will depend on what you do. If you're complying with treatment and if you restrict on your follow-up visits, then this child is going to be one of those who are doing very well and one of those who lead a normal life. The next principle is to stay true. I cannot emphasize more on staying true. It's a culture that we try to assure patients and relatives with false information. That's not professional. I know people think that, oh, you don't need to be harsh. It's not being harsh. Telling someone who's got cancer that he's got cancer is not harsh. It's giving them the fact that you're not going to change. So if we imagine a different scenario now, something was a more serious, something, let's say this child was diagnosed with acute leukemia, and then the question comes in, is my child going to die? Is Hussam going to die? Let's have the answers. We're all going to die. I have to tell you that leukemia is a dangerous disease. I know some children who survived leukemia. We will have to wait and see. It's not important now whether he's going to die or not. Let us focus on what we need to do on the short term. What do you think? We're all going to die at one stage. That's a fact of life, but that's not what she's asking about. It's a dangerous disease. How dangerous is dangerous? Is it going to kill him? She's asking a specific question. Is he going to die? Yes, I know cancer is dangerous, but you're not answering my question, sorry. I know children who survived leukemia. Yes, you know. Is Hussam going to be among them or not? We will have to wait and see. We've said that wait and see is when we have done everything is a little bit inappropriate in the initial meeting about someone who's been diagnosed with a condition. It's not important now. Let us focus on what we need to do now. Of course, it's a big red. So what do we say? How do we answer this question? We answer it with a fact. Well, with the currently available therapies, nearly 90% of children will be doing fine after 5 years of the diagnosis. This is a 5-year survival rate of the leukemia, and that's a true fact. And it's not a bad fact that 90%. So it's giving hope while staying true. It's giving hope based on a true piece of information. You need to show light. It's not all dark, dark, dark. You need to show light while staying true. You're telling me about those insulin injections. Will he have those injections every day for the rest of his life? What are the possible answers? Yes, is the only available treatment now. Unfortunately, yes. We can try other therapies and see. There are new treatments under trial. He will die without insulin. What do you think? This is green. Yes, we need to agree that insulin is the only treatment currently available for insulin-dependent diabetes in children. Unfortunately, it's green again. We can try other therapies and see. There are no other therapies for insulin-dependent diabetes. You're giving false hope. You're actually giving false medical information. There are new treatments under trial. That's a little bit tricky. There are other treatments under trial, but can we use them on Hussam now? The answer is no. So that's why we've given this a yellow. We'll see how to mix the hope with the fact now. He will die without insulin. Of course, we don't say that. It's a fact. He's going to die without insulin. But again, that's not what you need to say. How you mix hope with the fact. You say, clearly, insulin is the only treatment currently available for Hussam's condition. However, he's still 4 years old. There are new therapies are being tested for diabetes, and who knows, maybe in 1 or 2 years, one of those treatments will come out and he wouldn't need the insulin injections. But to answer your questions, at the moment, insulin is the only available treatment for Hussam's condition. So it's like a sandwich. You're giving that insulin is the only treatment. Then maybe in few years something out will come, which is true. But you end up with insisting that insulin is the only available treatment now. So it's what they call the sandwich technique. You give the fact, then the hope, then you repeat the fact again. So they don't leave you with any ambiguity in mind that insulin is not mandatory. You need to respond to emotions. If the mother is starting to cry, you remember in the spikes when in the part 1 of this lecture when we said have some tissues and a glass of water available, that was for that moment when the mother starts to cry. And she says, oh my God, why is this happening to me? Your answers might be something like, do you want me to stop? I know how you're feeling. I went through the same experience myself when my mother had diabetes. Kindly hold yourself, I need to carry on, there is a lot to do. Nothing is worth your tears. Of course, nothing is worth your tears is a joke, but let us put it there. What do you think about those answers? Do you want me to stop? That's a good answer. And maybe you don't need to ask if you see that is inappropriate to carry on. I know how your feelings. Maybe you will feel that will get a green, but you will be surprised that it will get a red. Because you don't say, I know how you're feeling. You might say, I appreciate your feelings. It must be a tough time for you. But to say, I know how you're feeling, there is, practical impossibility in that. No one can know how someone else is feeling. I went through the same experience myself. No, we're not here to call on your personal experiences. It's all about Hussam's mother. It doesn't help her that your mother has got diabetes as well. Kindly hold yourself, I need to carry on. That's a big red. You ask her to stop crying so that you can carry on throwing some more information on the poor mother. You don't do that. And of course, nothing is worth your tears. Was a joke in the first place. Would I cry with her? No. Empathy is to appreciate the feelings, not to share the feelings. You appreciate she must be feeling sadness and pain. But if she's crying, you don't cry with her. So empathy is appreciating, not sharing the feelings. You might say something like, I know it must be difficult and I appreciate your feelings. Would you like to have some water? Would you want me to stop? Do you want us to carry on another occasion? Do you want me to call on your husband to be with us? Something like that. So we're finished with the content part. We finished with the introduction and with the content, and then we go now to the conclusion. How do we make a conclusion? You summarize, you go through the sentences that you're saying, and actually you signpost. Can I summarize now? Then you actually give a quick summary of what you've said, and ask if the mother has any questions and answer them. And then further sources of information, leaflets, websites, something like that. Then you show support and further meetings. Come and meet myself, come and meet any of the team looking after Hussam at any time. We'll be more than happy to help you. And then you greet the mother and you leave. So that's the process of delivering bad news. You go through the introduction as we've practiced together now on the scenario. Then you're delivering the information, and then you go through a conclusion. I want to remind you to stay away from your dear ones if you feel unwell. What we've discussed in this two lectures is the basic model of communication. When do we communicate in the clinical environment, in the medical environment? How should we communicate? Whether we divide it into A, B, C, D, E, or whatever. And we've focused on the spikes, and we've simplified the spikes into introduction, delivering the content, and the conclusion. And we've done that with a famous example of telling the mother of a 4-year-old child that her child has got diabetes. I offer you this article for further reading. It's available on the Egyptian Knowledge Bank. I hope you all have your Knowledge Bank accounts by now. Thank you very much, and I'm hoping you all the best.